Welcome to our third basic CLL course. So we kicking off today with my co-chair, Professor George Follows, and big thank you to CLL Support Association, who did a huge amount of work and do all the logistics for this course.
Yes, it's very kind of you, the CLL Forum and the CLL Supporters Association, to invite me to co-chair with Renata. The way the structure works is then, obviously, Nick, we want you to join me and Renata, and Lelia and John from the CLL SA are going to come on, and then we're going to have a panel discussion around the topics that you have raised in your slide. So I'll hand over to you, Nick, if that's all right.
Thank you, George, for the kind introduction. So Relapsed CLL. As Renata's mentioned, we're starting the house by the roof in this course this time round. But I think the order is slightly relevant. I think it can be treated as standalone sub talks. So let's begin by stating perhaps the obvious. That the CLL is becoming a disease of the elderly, and as you know, the median age of diagnosis is 70 years, and we'll dwell into this point a little bit later. But most of these patients will have 5, 10, 15-year survival. So it's becoming a more of an elder treatment scenario when you're dealing with relapsed CLL, and that's certainly been what I've seen in my practice in this last few years. And to begin with, perhaps important to say that to treat CLL, you need to have all the cards on the table, if at all possible. And so the three main principles for this. First one is that you should reassess the status of the 17p deletion and TP53 mutation. If you haven't done before, obviously, but even if you have, because there is now quite robust evidence to say that these mutations and deletions can emerge throughout treatment, that will definitely change your approach to your choice of therapy and then the planning ahead for the relapsed CLL. The other testing for mutations, which is available through NHS for everyone, really, is the assessment of BTK, BCL2, and PLC gamma2 mutations, which are mutations on the pathway of either BCL2 signaling or the BTK signaling that may be relevant to your treatment choices in relapsed CLL. And it's the sort of data that is always helpful to make decisions in the long term. And IGHV, however, on the other hand, is a basic and intrinsically stable biological feature of CLL. So it doesn't necessarily need to be repeated at every line of therapy, because this is not going to change at relapse. So this is a glimpse of what the updated guideline is going to look like. It's perhaps also stating the obvious that your choice of second and third line treatment will clearly depend on what you have used before. And in principle, as you can see here on the right-hand side of the slide, if you have used BTKI upfront on the first line therapy, then it's quite often recommended to change to BCL2 inhibitor therapy, venetoclax-based therapy, because most of these patients will have been treated until progression. Whereas on the opposite side of the slide, if you have used venetoclax fixed duration regimens as they're available in combination with either obinutuzumab or ibrutinib, depends on the length of your remission, you might have an opportunity to retreat these patients with venetoclax or change mechanism of action to a BTK inhibitor. And it works for both regimens. And more importantly here, if you are treating for a second time, it is important that you should follow the same IWCLL criteria for treatment, and disease progression doesn't necessarily always mean a start of subsequent line of therapy, and we have learned through experience with fixed duration studies that the time off therapy is very valuable for patients, and being off therapy without being exposed to side effects from treatment is beneficial, and there's always a discussion that needs to be had with patients into how much their symptoms are currently and how much are those criteria being met at present. And if we go further down the line on third line therapy and beyond, again, retreatment with venetoclax is an option, particularly if you have used it in the first line, you haven't used it second line. Then the PI3K inhibitors come in here, idelalisib particularly, and there are many patients who will have no options left of novel agents, and for whom, if they haven't received chemoimmunotherapy before, one wonders if there is any scope of retreating them with, or treating them with chemoimmunotherapy at all. The bottom line is there is no evidence for this at all. So it is an evidence-free zone, but it's possible that we will encounter this issue in the future. We might resort to chemoimmunotherapy. There's no other option left. I don't think we've ever come across that case yet, at least not myself in my practice. And then allogeneic stem cell transplant, also an option for patients in selected circumstances, particularly younger patients with TP53 aberrant disease, etc. So in essence, therapy with BTK inhibitors or venetoclax-based therapy is what you have available in CLL, in relapsed CLL. And the message here is that the choice remains binary. So you either go for a fixed duration therapy with venetoclax, or you either go with a continuous BCR inhibitor therapy. But this is a very complex decision, even though it's binary. And you have to take into account the TP53 status, cytogenetics, IGHV mutation, ECOG and age, but also, importantly, patient preference, comorbidities, and what the medication the patient is on. So dwelling on the issue I alluded in the first slide, the treatment goal of the patient is important. And if you think about a patient whose median age is 70 when a diagnosis, then they have a 2-3 year period of watch and wait. Then they have a first line therapy which has a prolonged PFS, 6, 7, 8 years, as we commonly see in the first line clinical studies. Then you're looking at a patient who's 80 and who's needing at some point second line therapy. And then the goal of treatment and the tolerance to therapies from a patient who's in their 70s can be completely different to the person on their 80s, and something to really keep at the top of your mind when you're making the choice. So we're going to summarize the pivotal trials, or the relevant trials, in relapsed and refractory CLL, and you can see we've got 3 important studies for BTK inhibitors and one for BCL2 inhibitors. We'll go through most of them, not all of them, in the interest of time. And we'll be going one by one. So we'll start by the venetoclax fixed duration therapy, which is based on the results of the Mirana trial, which was published already a few years ago. So as a reminder, for people who might not be as familiar with Mirana's study, that randomized patients to be treated with venetoclax and rituximab compared to bendamustine and rituximab at the time where chemoimmunotherapy was still an option. And if you're completely naive to the subject, you will say, well, you're telling people that, you know, we don't treat patients with chemoimmunotherapy anymore. And that is true currently, but at the time of the study design, this was still a relevant and accepted option. So these patients have 2 years of fixed duration therapy, and the primary input of the study is progression-free survival. And there is, interestingly, a sub-study of this, which is on the right-hand side of the slide, as you can see, which we will touch in a moment. I'm going to use it. Yeah, so this part of the sub-study, which I think gives us significant and relevant information. So a couple of broad messages from the baseline characteristics of these patients, typical median age, and enriched for unmutated IGHV, as you would expect for a relapsed population. Relatively low numbers of TP53 and 17p deleted for a relapsed population, but nevertheless relevant. And this is probably the main thing to point out about the Marano study, is that most of these patients had one line of prior therapy, and most of that prior line of therapy was chemoimmunotherapy. So if you think about a patient as going to venetoclax rituximab currently, who's had BTK inhibitor first line and then relapsing and is going to the venetoclax rituximab second line therapy, it is clear that the data from the Marano study doesn't quite apply to them. And that's one of the main caveats of the interpretation of the study of the Marano study, which is that it is obviously difficult to extrapolate to a current population. With that caveat, the PFS endpoint was met early on. So you can see the big difference in the rate of progression, being 84% of still progression-free at 2 years for the venetoclax rituximab and only 36% for the BR arm. Again, significant difference with significant reduction in the risk of progression. So what happens later on? We've now got 7 years of follow-up for this. So as you can, and the median PFS is 54%. So we've got nearly 6 years, and still half the patients are progression-free at 6 years post-treatment, which is quite significant for a fixed duration therapy. Just you're thinking, just remind people that you're looking at people who have had 4 or more years of a treatment-free period, which I think is the most relevant outcome of this study. And the other important aspect is that the overall survival is improved with the use of venetoclax rituximab, even despite subsequent use of novel agents. So having a deep remission as it is obtained with the venetoclax rituximab in the majority of patients seems to confer these patients with a survival advantage. And further to that point, the achieving undetectable measurable residual disease is relevant, and the deeper it is, the better the progression-free survival and the overall survival is for these patients, as is demonstrated by these curves, in which the green ones are the ones that are MRD negative. Side effects are pretty much what we know already about venetoclax, or what we knew before Marano study, or what we expected. Significant hematological toxicity, neutropenia, mostly, and infections is the most common complications. Tumor lysis syndrome was rare, only 3% of cases, and you can see 8% pneumonia, 3.6% febrile neutropenia, 17% infection. So recurrently, the theme here is the risk of infection. So, as I mentioned, the caveat is the low proportion of patients who were BTK exposed, and what happened with patients who've had other lines of treatments prior to venetoclax that were not chemoimmunotherapy. So the 2 different ways we can answer these questions, which are not randomized studies, unfortunately, but they're real-world studies that have looked at what's the response of patients with according to the previous line of treatment when they go into venetoclax rituximab. It's a real-world American study, and it can shows here that the progression-free survival is about the median is about 25 months, with only median overall survival of 4 to 6 months. So it does look like these patients had 2 and more lines of therapy. Most of them had previous chemoimmunotherapy. 72% of those have had ibrutinib before. So this study demonstrates that the good outcomes that are seen on the Marano study are for those who have been receiving VENAR on the second line, and perhaps for those who receive then our third and fourth line, as it happens for some of our patients, the outcome is not as good as the overall Mirana population. This seems obvious if you think about it, but this is a retrospective study that does demonstrate that quite clearly. And then for the BTK exposed, the core CLL study, which is an international effort trying to collect real world data for CLL, has shown in a large cohort of nearly 4,000 CLL patients, that they've been able to find a small cohort of 65 patients who've had BNR followed by or following BTKI inhibitor therapy. And in these patients, the response rate was 41% and the median PFS was 43 months. Just to remind you, the one for Mirana study was 54 months. So again, it seems like but this is a real world study and is not specifically a trial population, which is not unexpected. We are used to seeing real world results being slightly less good than the trial population, but nevertheless shows that venetoclax rituximab is still very active and a very good choice for patients after BTKI inhibitor therapy. And finally, the sub-study, which is the part I'll show you on the right-hand side of the study design, which is testing what happens with patients who have relapsed after venetoclax rituximab when they have been retreated with the same combination, venetoclax rituximab. So importantly here, I direct your eyes to the bottom of the slide. So best response rate 72%, median PFS 23 months, and the 3-year overall survival 53%. So again, not as good as when it's used on the prior line of therapy during the Mirana study, but again, quite relevant outcomes. The more important thing here to highlight is the treatment interval, so the time between the two venetoclax rituximab lines, and the median time for this is 2.3 years, and the range is 1.2 and 3.1. So it's relevant because we still don't know what the optimal time window between the retreatments of venetoclax is, and we tend to say 2 years as a as a rounded figure, to say if you have relapse after 2 years, you will be a good candidate to have been retreated with venetoclax. Basically, this data is showing us that nobody's retreated patients with venetoclax that have relapsed before 1 year or during the first year after completing venetoclax. Therefore, we've got no evidence to retreat patients that have relapsed before 1 year, and that probably is not advisable on the light of lack of evidence, really. And perhaps this median interval of 2.3 years is probably what's driving that evidence or that kind of consensus around that figure of 2 years, allowing retreatment with venetoclax. But again, evidence is scant, and the numbers are as small as you see. Only 25 patients have been included in this study. And importantly, there've been genetic testing that was performed in 42 patients that have relapsed after venetoclax, looking at BCL2 mutations, because we know that BCL2 mutations are not the only one, but a relevant mechanism of resistance to the venetoclax when it was used continuously before. And now that we have a good cohort of these patients that have been given fixed duration therapy with venetoclax, we have observed that there is very little occurrence of these BCL2 mutations. So definitely another demonstration that the fixed duration therapy tends to protect patients for the emergence of mutations, specifically against the pathway we're targeting, in this case BCL2. But there are other families of this or proteins of the same family that sometimes have been associated with mutations that can confer resistance to venetoclax, and this is something to take into account. And this is a much more complex sort of intracellular signaling structure that needs handling and analyzing with a bit of care, as opposed to the BTKI, I think, signaling, etc. So that's for the fixed duration. And now, if you decide that your best option is continuous-based therapy, BTKI-based therapy, then what are your options? So we've got I'm going to touch on these 3 studies, and I'm not going to touch on the ASCENT study, which I don't think adds too much to the discussion, particularly for today's presentation, and obviously in the interest of time to allow us to talk about some of the ASH results. So these 3 studies, we're going to go one by one. Alpine is a study that has combined, or that has randomized patients to be treated with zanubrutinib or ibrutinib. This is a super, and I'm going to touch on some statistical nuances here. So this is a superiority study, but its primary endpoint is response rate. So it's tested, so is designed to test that one is superior to the other based only on the response rate. So then the differences we're seeing on the progression-free survival, it doesn't necessarily mean they're not real, but the study wasn't powered enough to detect those differences. And this is something important when we try to interpret the results of these data. The population was a very typical, again, relapsed population enriched for mutated IGHV and TP53 aberrations. The median time on treatment is now currently about 40 months, so nearly 3.5 years-ish of follow-up after treatment, which is relatively short if you think about CLL. Also, 75% of these patients have had prior chemotherapy. So again, if we think about extrapolation, we still have very scant evidence about how is the outcome of these 2 agents following venetoclax-based therapy given on first line, because of the minority of patients being included in this study that received venetoclax up front. So progression-free survival that has shown an improvement with about 32% reduction on the risk of progression from zanubrutinib, which was 64% at 3 years, and obviously improved response rate and roughly similar overall survival at 36 months. Again, important to know that this is not the primary endpoint, but it does look relevant, and we're going to analyze some subgroups that might shed us some light into why is this difference appearing here between these 2 agents. So we analyze the response according to most of the different categories and characteristics of the patients, and there's no signal as to a specific subgroup of population that would benefit more from zanubrutinib than others. And you look at the progression-free survival, it similarly, so looking at baseline characteristics and disease characteristics, there isn't anyone that really highlights as to zanubrutinib being better than ibrutinib significantly. However, if you look at the geographical region that I show this on this graph at the sort of bottom right-hand side of the slide, you can see there is significant improvement on the progression-free survival of zanubrutinib of patients who were treated in Asia and North America, which is quite striking. This is one of the main, and this is not quite explained with a lot of detail. Why is that? We don't know if these patients have been maybe stopped ibrutinib treatment earlier than they should have because of side effects or some other health-related or healthcare system-related problems, or specific sort of standard of care or sort of standard practice in the countries that was used. But clearly seems like the improvement of progression-free survival that we see from zanubrutinib is driven by the patients that were treated in Asia and North America. If you look at Europe, there's virtually no difference between zanubrutinib and ibrutinib. Still, that still hasn't been fully answered, but important to highlight these little differences here. The improvement is maintained on the P53 or 17p deleted population, and again, without entering into the debate as to whether or not this is really superior or not, based on this being an exploratory endpoint and not having statistical power to detect this difference, it does look quite significant, and it follows the pattern of all the other BTK inhibitors, in which 17p deleted and TP53 mutated patients perform nearly as good as as the ones that are TP53 naive. So this clearly demonstrates that in terms of percentages, and demonstrates that this is a good choice for patients with these aberrations. In general, the treatment adverse events tend to be lower with zanubrutinib than ibrutinib, and you can see all the percentages being slightly lower on the zanubrutinib column here. But the most relevant, or the relevant ones, are the atrial fibrillation, as you can see highlighted there, which is significantly lower with zanubrutinib. And you can see on the right-hand side the curve of the cumulative incidence of atrial fibrillation throughout treatment. You can see the significant difference there is between ibrutinib. So cardiac safety seems to be a significant issue. And please keep on your retina as the figure for the hypertension that we'll go back to it in a few slides. So that is for the comparison between zanubrutinib and ibrutinib. Now, ELEVATE-RR, which is similar study, phase 3, comparing ibrutinib plus one of the second generation BTK inhibitors, that is the acalabrutinib. But again, the slight difference is this is a non-inferiority study, and the primary endpoint is PFS. So this, the results that we see on the progression-free survival in the study are relevant, are perhaps more relevant, because this was powered to detect these differences. The population, again, not significant difference, perhaps slightly more IGHV mutated and TP53 deleted patients. So again, heavily pretreated, but reflecting a pretreated CLL population with a median line of prior lines of therapy of 2. And progression-free survival, as you can see, is pretty much identical. There's no difference in progression-free survival between those two agents, independently of all the subgroup analysis that you can see. So there's no specific subpopulation depending on the IGHV or TP53 status or other cytogenetic abnormalities that would favor for one or the other. And safety outcomes are worth noting here. And just remember, I told you to keep on your retina as a figure for hypertension. If you'd like to go, so you can see the hypertension related to acalabrutinib, which seems to be much less compared to zanubrutinib. And the rate of atrial fibrillation is slightly lower, again, for acalabrutinib compared to ibrutinib. All the other relevant side effects, such as diarrhea, that you can see on the left-hand side, is also significantly lower. So again, the gist of these two studies is that both acalabrutinib and zanubrutinib tend to be safer compared to ibrutinib, the second generation, and there are several molecular reasons why they have they're more selective and hence have less undesirable side effects. And you can see here the cumulative incidence of atrial fibrillation and hypertension. So the thing here is that we will never have a randomized comparison between acalabrutinib and zanubrutinib, and therefore we will not be able to know on a prospective fashion which one is relevant, is better than the other in a way we can really compare them. We'll touch into that in a few slides as well, because there are ways we can compare them indirectly. So the third one is the RESONATE study, and although it's a bit of a classic study now, I would say, if I can call it that way, I think there are some important messages that we can take from the RESONATE study. So obviously, comparator arm is ofatumumab, which is completely irrelevant for current CLL population, but acceptable at the time of the study design again. But it has randomized patients to receive the BTK inhibitor or not, and with PFS as a primary endpoint. Again, pre-treated population with a median number of lines of treatment of 3, and a significant proportion of 17p deletion. And at the time, no data for TP53 mutation, because it wasn't as widespread tested as it is now. So this is also question mark we have about the RESONATE study results. And the progression-free survival is 40% at 74 months, which is probably the longest follow-up we've got on BTK inhibitor studies. And without looking at the comparator arm, which again, I think it's irrelevant, it's important because when you're counseling your patients about BTK inhibitor therapy, and we take into account that we believe that acalabrutinib and zanubrutinib are at least equivalent to ibrutinib. So this is sort of the long-term picture that we can paint our patients when we're starting them BTK inhibitor therapy. So 60 months, so 5 years later, there's still 40% of patients that are in drug. And this is a much heavier, heavily pretreated population than the one we are probably getting into BTK inhibitors now at relapse. So still very relevant. And if you have a patient that has experienced already 6 or 7 years of remission after venetoclax-based duration therapy, this is not unreasonable to expect this sort of progression-free survival for a BTKI second line, for example. And the other relevant details that we can extract from the RESONATE studies is that it has the longest follow-up of patients monitoring adverse events related to BTK inhibitors. And we now know that 5 and more years down the line, these side effects continue to be emerging in regular fashion. So this is relevant because we now can counsel our patients on what to expect from their arthralgia, from their hypertension, from their diarrhea, from their risk of infections, from their tendency to bleeding, etc. And this is something that is cumulative and ongoing and will not disappear until the treatment is interrupted. So, like I said, we were not going to have a direct comparison between zanubrutinib and acalabrutinib, hardly ever, probably in a randomized fashion, but there are statistical ways we can look at this, and these are called indirect treatment comparisons, which is a way to indirectly compare two different studies. This has been done mostly for first-line treatment, but I think it's relevant in the relapse setting because this is it's called MAIC, Match Adjust Indirect Comparison, comparing the first-line data between these two studies. I think it's relevant because the efficacy is very similar, matching by different populations. What they do is they take the two different studies and they try to extract the population of the two patients that are most similar to one another and compare it head-to-head. So you can see the numbers are smaller because the number of patients that are actually matching with one another are less than the bigger trial population. That has a consequence, and that means that the conclusions are less stringent, statistically speaking, because the number of subjects becomes smaller. But it gives us relevant comparison. And the thing I'm most likely to point out here is the right-hand side of the slide, which is the safety comparison. Like again, as you can see, the acalabrutinib slightly favors here the hypertension that you can see highlighted here, and which is the only side effect in the match comparison that has become as relevantly or statistically significantly improved from acalabrutinib as compared to zanubrutinib. And that means if you have a patient with a difficult to control hypertension, probably acalabrutinib should be your BTK of choice. That doesn't mean that if you have a patient with hypertension in general, you shouldn't give them zanubrutinib, because the hypertension in general is a side effect that is well managed in patients who are having BTK inhibitors, but something to think about as perhaps the only differentiating factor we've got. The other ones, and that by that mean risk of infection, risk of bleeding, and minor side effects such as arthralgia, diarrhea, etc., are pretty much comparable. Right, so a brief mention of venetoclax-based therapy. This is we don't have much evidence about this, so we keep saying that patients should be eligible for venetoclax-based therapy given until progression if they relapse after a venetoclax-based regimen. And this has been accepted by our regulators, but the evidence for this is a small study. It 116 patients, and this was published back in 2016. So it's the evidence that's nearly 10 years older, and we don't have much more evidence of sort of continuous venetoclax therapy since then. So it's theoretically a good option. Just highlight not the strongest evidence for this. But again, progression-free survival of median progression-free survival of about 2 years, which is what we now what we knew to expect from the venetoclax continuous therapy after failing several other lines of treatment, and remains relevant perhaps for these patients who received fixed duration venetoclax, continuous venetoclax at some point later in the pathway of treatment. But importantly, this study has helped to establish the definitive dose of venetoclax, which, as you can see here, is 400 milligrams, but importantly, also to demonstrate that there isn't a huge difference between 17p deleted patients and not. We don't have data for TP53 mutations here, unfortunately. So to finalize in these last 10 minutes, perhaps, of my talk, a few words about switching and sequencing. This is a slide from John Seymour that highlights the pathway of treatments depends on which choice you take, first line, second line, third line, etc. It's not meant to be prescriptive, but it's just meant to highlight that we've got new players in the field here, the non-covalent BTK inhibitors that are coming, the BTK degraders and the allogeneic stem cell transplant that continue to be option later down the line, and we're in the process of putting them in the right place in this sort of tree of treatments going forward. And that will be the task of the CLL clinical research in the next sort of 5 to 10 years, probably. And that gives me and some other relevant aspects that are relevant for sequencing. This is data that is emerging from Captivate study, which has tested how do the patients respond after having ibrutinib and venetoclax at first-line therapy, and how many of them have been able to be retreated with ibrutinib and venetoclax or with ibrutinib single agent after at the time of progression. And numbers are still small, so take that with a pinch of salt, but again, good response rate initially for patients who've been re-exposed to both venetoclax-based and BTK-based inhibitor therapy. So meaning that using fixed duration therapy, as we've demonstrated for the Murano study, is probably maintaining relevant clinical and sensitivity to these agents following subsequent lines of therapy, and that is something that should be probably clear from this presentation, that it is useful to reuse these agents further down the line. The other important aspect to highlight here about sequencing is that there are now 2 different studies that have demonstrated that most of the side effects, particularly if your patient is on ibrutinib, do not recur if you change your patient to a different BTK inhibitor. And the left-hand side is ibrutinib, acalabrutinib in ibrutinib intolerant cohorts, and the right-hand side is zanubrutinib in those who are intolerant to both either acalabrutinib or ibrutinib. And most of these patients have adverse events that do not recur at a lower grade compared to previously. So this is a message to say, if you're having trouble with your BTK inhibitor, think about switching to a different one. And before you deem your patient as intolerant to BTK inhibitors and think about a different line of therapy or stopping the treatment altogether, it is relevant to change. Sometimes it's helpful. This is a brief example of a case, or a brief case that I want to use to highlight specifically the non-covalent BTK inhibitors. This is a story of a man who is 72 who had venetoclax obinutuzumab first line and had a 3-year progression-free survival. He had acalabrutinib for his second line of therapy and only had a 2-year progression-free survival. He had no TP53 aberration but had a BTK mutation. Therefore, here the question is, what do you give this patient? Can you give venetoclax with rituximab, or would you be able to give a BTK inhibitor even if it's a non-covalent, because you have a BTK mutation here? And this will give me the possibility to talk about non-covalent BTK inhibitors. Answer to the case report, both are good options, but importantly, the non-covalent BTK inhibitors are still relevant even in the case of BTK mutations, and I'm going to expand on that in the next few slides. So the non-covalent BTK inhibitors are coming. They're a novel class of drugs, sorry, which is sort of cousin of the covalent BTK inhibitors, and they bind to the pouch of the BTK slightly differently. So they don't use this amino acid, which is this C481, which is where most of the mutations occur. So they're independent of that amino acid. So if there is a mutation there, they will still bind and be effectively inhibit the BTK inhibition or the BTK functionality. So even if these mutations are there, the non-covalent BTK inhibitors can still work because they bind differently to the molecule. So two quick mentions of this, which is pirtobrutinib, which is the one that is perhaps most advanced. There are other agents with a similar mechanism of action that are coming. This is the first study that demonstrated in a cohort of nearly 280 patients that the response rates were about 80%, independently of whether or not you had previous venetoclax or not, and the progression-free survival, which is about 38% at 2 years. Which, you think about it, isn't great, but these patients have been, most of them, exposed to both available class of novel agents at the time of inclusion of this study, and they still get relevant time of good response with the drug, and some of them achieve a complete remission. And the response was irrespective of whatever they received previously, whether or not they had a BTK mutation before, and whether or not they discontinued due to progression or other reasons. And this has led to the development of further clinical studies. So this is the first ASH, so Pearl, I drop you in today, which is the Bruin study, a randomized study which compares pirtobrutinib to idelalisib rituximab. These patients have been heavily pretreated. Median line of treatments were 3 or more, and as you can see, significant proportion with BTK and PLC gamma2 mutations, which are known to drive resistance to BTK inhibitors. Relevant, so progression-free survival median is 15 months. With a median follow-up of 19 months, which is significantly better to what we have with idelalisib and rituximab, and this means that pirtobrutinib and the non-covalent BTK inhibitors are likely to be sort of the third novel agent of choice after you fail venetoclax and BTK inhibitors. And it continues, it has similar efficacy irrespective of whether you've got the the TP53 mutation or 17p deletion, and respective of the IGHV status. So very encouraging results that hopefully will consolidate pirtobrutinib in this sort of slot of sequencing of treatment. And quite relevantly, you can see this graph is there to show that the C481 mutation here rarely appears when you treat these patients with pirtobrutinib. So because they don't use that amino acid to link into the protein, the mutations that come up when you treat patients with pirtobrutinib are different. And therefore, we know theoretically you could sequence covalent and non-covalent BTK inhibitors. And we have now evidence from this Bruin study I've just shown you that you can use pirtobrutinib after covalent BTK inhibitors. Theoretically, you could use the other way around, but we don't have yet evidence for that. And that the jury's out there to see if we demonstrate that, and then we make the BTK inhibitors interchangeably, one after the other. 2 or 3 more minutes to talk to you about other breakthroughs from ASH. This is the first in human trial of the BTK degraders. There are 2 different studies, left and right hand side of the slide. And the technology, which is depicted on the picture that you can see on the top of the slide, which is quite significant. So the degrader is a small protein that you can see here in red. And what it does is links the protein that you want to target, which in this case is the BTK, and links it with a complex of protein that we called E3 ligase complex, which is basically naturally functioning protein that tags the other proteins for degradation. So if you have a protein in your cells that is not needed anymore, the E3 ligase is the one that tags it for destruction, basically. So this protein, what it does is that it brings together the protein that you want with this complex in order for it to be tagged and degraded. So in this way, we can sort of degrade BTK molecules very actively, very effectively, using the cell's own machinery, which is a very clever way to do it. It's a much smaller molecule, and it's very, very effective. So the results from the 2 different BTK inhibitors, one is coming from Nurix Therapeutic, and the other one is coming from a Biogen company. The early efficacy is very much the same. As you can see, the response rate is very similar. And the adverse events profile preliminary is very similar to what we have observed on the BTK inhibitors. Essentially, you are blocking the functionality of the BTK, so you would expect the side effects to be the same, and there's no significant sort of additional side effects that we need to be worried about. So very early data, but very encouraging. This is something that we'll be seeing in the CLL landscape in the next few years, probably. Another 2 snippets of ASH to finalize CAR T-cell therapy. The Transcend CLL4 study was presented. The CLL Transcend, I should say the Transcend studies that were originally done to test the CAR T-cell therapy were not as good as we thought they would be. And for this study, what they've done is combine the CAR T-cell therapy with ibrutinib in patients who've been previously exposed to ibrutinib, etc. But they use the ibrutinib as a form of sort of immune modulation, and they actually obtain a much better response than they did originally with the CAR T on its own. So something quite relevant and potentially for the use of CAR T-cell therapy in CLL patients. And on the right-hand side, this is just a study that has been done looking at patients who have responded to CAR T-cell therapy, albeit there have been a minority, and well, it was rather disappointing. Those who have responded at 1 year have a overall survival and progression-free survival that is really good. These were patients that were had no other treatment options, and if they achieve a good response with CAR T-cell therapy, the outlook seems to be pretty good. I'm going to leave it there. I think I've had another bit of data from ASH, but I think in the interest of discussion, I'm gonna stop, and I'm happy to hear any comments and questions from both the chairs and the audience. And I thank you for your attention.
So Nick, we could maybe bring Renata. This is a question about the BSH guidelines. I couldn't see an intolerance arrow below BTK inhibitor. And let me flesh out this question. A lot of us have got first-line BTK patients who have chosen to stop, mostly through intolerance, but sometimes we've got patients who simply get fed up taking tablets. And we know there is this building real-world data set and a data set spinning off from first-line trials that patients who've taken BTK inhibitors for 1, 2, 3+ years and stop are often not relapsing, are they? And I think in everyday practice in the UK now, we're often saying, well, look, particularly NHS England Blue Tech, you can get approval to reuse a BTK. So why would you start again if somebody's been on their ACAL, Azano, ibrutinib, stopped for an adverse event or for personal reasons? 2, 3, 4 years later, we can restart them on a BTK. And I couldn't see on the BSH guidelines arrow, if you've stopped for intolerance with BTK, whether we would perceive restart BTK as in effect a package of first-line care. So you're just still wrapping that up as BTK, or do we need to clarify that? Do you have any comments?
I think to an extent that probably will be I think within the guidelines probably it's still considered as first line therapy because you now have actually failed, but it's a relevant point, and I take the opportunity to highlight that the UK CLL community is trying to answer that question actually with the static study, which is a study that is going to follow on from the FLAIR study, which most of the audience will be familiar with, and we're trying to test whether or not stopping BTK is feasible in these patients and following them up closely to restart BTKI when they have signs of early progression and see if the BTK is still active on those patients, and giving them some treatment-free period, and seeing how many patients are actually treatment-free for long periods of time after stopping. As you quite rightly point, there are many patients that are very well after stopping BTKI.
Seeing, Nick, your very, very balanced presentation of the relapse trials, that we're all faced with this BTKI question in relapse. What drug do you choose? And of course, in the first line, we have choice as well. But I'm struck, Leila, let me put you on the spot here. Much more often, patients, particularly in the 70s, ask me about toxicity of a continuous drug rather than efficacy. Am I going to be on this drug for 42 months or 44 months? Isn't at the top of their question list. It's how am I going to be at my granddaughter's wedding? So, Leila, patient view on that question.
Absolutely. I think it's a really important question for people with CLL. And I thought that when Nick was showing the comparative side adverse events for the different BTKIs, and the medics always go to the atrial fibrillation, high blood pressure, but it's things like fatigue comes up as the number one concern amongst people with CLL. And it just caught my eye, for example, that acalabrutinib looked like fatigue was slightly higher than for ibrutinib. And that, if you talk that over with somebody you're offering treatment to, who, for some people fatigue isn't a big issue, but for others it will be. So I think it's actually one of the factors that if the more information there is about adverse events and side effects, that becomes part. I mean, John's going to talk about shared decision making later, but that's really important information in terms of making a decision about what treatment you start in the first place, I think.
Yeah, I remember on that point, I moved a patient once from ibrutinib across to acala in a clinical trial, a fairly soft phase 4 trial. And the main reason he had this terrible arthralgias. And I put him on the acala and his arthralgias went. And he came into the clinic and I said, anything else? He said, great relief. I don't have to go to the toilet constantly. I said, but you'd never reported that. He says, ibrutinib. I just couldn't really go out because he got bad diarrhea, which had improved on. And it was just a reminder to me that patients tolerate a lot of what we would perceive as perhaps low-level side effects by just adjusting their life. And actually, sometimes the patients need to be a bit more honest with us.
But also I think you can facilitate that by asking them.
Absolutely.
Because often it takes a while to realise it's a blooming side effect. Particularly a lot of us are on multiple treatments. Yeah. And you guys know, you people know, apologies, Renata, you know that what the side effects are. And often it takes weeks. You feel stupid because you eventually realise this is a side effect of my treatment. And it because often they think like diarrhea or bowel problems creep up on you and you don't necessarily associate it with changes in your treatment. So I think that's something that the CLL professionals can do an enormous amount to educate people about what the side effects are and how to report them back to you and how to discuss them with you. And certain ones are much more difficult to bring up in conversation with your doctor than others.
I've heard Paulo Gia once saying that obviously progression-free survival is very good endpoint for doctors. For patients is the side effects. And I think it's, yes, as you say,
progression-free survival. Sorry, Renata, I agree. Progression, I can't even say it properly, is not hugely meaningful to people with CLL.
to a certain extent, it's like, and if you look back at the first slide or first or second slide that Nick showed, you know, that the betting table, you know, it's kind of that perspective. But with regard to side effects, from a patient perspective, quite often there's a kind of a muss and grumble type attitude, you know. And however, we get a lot of feedback from some patients who tell us that, well, I reported those side effects and they said, yeah, that's one of the side effects, kind of, you know, put up with it. And that's maybe fine insofar as you can't do anything specific. But at our conferences, especially in the round tables discussions, the coping strategies that people with CLL have come up with and share with each other is absolute gold dust. And it's really interesting to see how resilient some people are and their ability to put up with side effects, which otherwise can be quite debilitating. And those of us who manage to combat fatigue and get the benefit of exercise find that anecdotally at least, the side effect burden is less. And you know, it's part of my talk later on with regard to managing side effects.
Yeah. I was very closely involved with the Bruin study and lucky enough to be one of the authors. And today in my clinic, I was speaking to one of my Bruin patients, and this treat beyond progression is a very interesting point, because I know you were really pushed as to how much time you could spend on the ASH presentations, but it's quite striking if you track the pirtobrutinib arm, that those of us who've been using pirtobrutinib in the trials are struck by how well tolerated the medication is. And a lot of these progression events are, of course, classic clinical trial progressions with, you can see the CT scan progressions because it's when they do the things. But the time to next treatment is disproportionately long in the pirtobrutinib arm. Now, I know there's a lot of debate about time to next treatment, and I have expressed my own cynicism on that as an endpoint when I was presenting last year at ASH. But they are but with Lily have listened. The time to next treatment includes death or another treatment event, and patients were allowed to continue pirtobrutinib if the physician or patient wanted to stay on drug. And you'll see that this is very protracted time. I think from memory it was 18 to 25 months. I'll have to clarify that figure, but it's just showing patients can derive many months of ongoing benefit. And my particular long story, my patient today, which I've just got him signed off because they are actually changing the trial design with ongoing follow-up to stop so much treatment beyond progression. And it is a difficult area because all of us in everyday clinical practice with the covalent BTKs are quite comfortable with that, aren't we? We'll see a bit of progression on Acala or something or Zano, and the patient feels quite well. We don't feel in an enormous rush to move on.
Yeah.
Yeah, and I think that's an interest in a real on-the-ground, day-to-day thing. You can often extend your use of these drugs for 6 months, 12 months. I think Pirto is going to show, hopefully, the same principle. I don't know whether you got that type of impression when you were seeing the data being presented.
Well, yeah, I agree with you, and we actually in this forum we've discussed several times that the time to progression, time to new treatment is much more a sort of endpoint, patient-friendly endpoint, and something that the patients can relate more to, because that's really what's telling them, you know, when things become a problem and they need some other treatment again, etc. So and we have seen it increasingly being presented with other studies, you know, kind of consistently being presented in the conferences and in the papers. And I think most of it is patient derived advocacy saying this is a relevant endpoint and is relevant information to know and to share with the community.
Sorry, anonymous attendee asking a question where we think pirtobrutinib is going to fit in the sequencing. And I guess we're probably going to be restricted by what NICE NHS England permit us. Do you think that's likely, or do you think we'll be given free rein in the relapse setting?
No, I think it will be restricted as per the trial population to those who have now failed both of the other novel agents, so BTKI, covalent BTKI, and BCL2 inhibitors.
the trial was only BTKI, so it was analysed. They had the two separate groups.
Yeah,
but
I believe the NICE might just use it as a third sort of novel agent strategy. I think that's my prediction. But Perto's being tested in other sort of studies, second and even frontline now. We've got some early studies that are in first line. So we'll see whether or not that evolves. And as I said, whether we can invert the pie and say, can we use the non-covalent BTK inhibitors first and then use the covalent BTK inhibitors after, as interchangeably as we have as we're doing now. And it's theoretically possible. And if we think the non-covalent are better tolerated, then this is the main reason why they perhaps should be used earlier than the others, if that really holds true.
Yes, it's interesting. Obviously, the chief executives of these pharma companies who spent literally billions on buying up these drugs are clearly wedded to the idea that non-covalent will be better than covalent. But actually, we don't know. We really don't know that. So we can't necessarily invert the order of events. Just before, I know we're going to move on to the second half of the talk. John kindly said he wouldn't be talking for the full 40 minutes. So I think we've got a little bit of leeway. Let me just put you, there's one question about sequencing that I always think about from a slightly philosophical perspective, and it's a good news story for the patient groups, that when we get sequencing data, it is always enriched by the bad players. And I couldn't help myself doing a bit of mental maths when I was watching, when you were presenting the Murano subgroup and the retreatment, because as you said, the retreatment, the median was an interval of 2 years. And in effect, we saw a halving of the progression-free survival. So venetoclax does seem to fit like the traditional oncology drugs, that when you use it, you sort of get half your return again. I think that this is such broad statement, broad brush. But of course, those patients had 2 years on drug, 2 years off drug, the average. And so we were still looking at patients that were on the more tricky side of that equation. And we've had Murano around actually since, it's pre-COVID, wasn't it? Our first patients going onto that protocol in the NHS. And my very first patient I treated is still on just an annual review, totally well. And of course, that type of patient, when they end up 4, 5, 6, 7 years off venetoclax, could really benefit from the retreatment. And I think this whole thing about sequencing, we're naturally drawn into the data sets, which can't help but be enriched by the difficult patients, because they're the ones that have been presented earlier. So they're the ones that have to have relapsed earlier. And yet big chunks of patients will benefit more and more from the sequencing and getting very protracted remissions, because those patients just haven't been reported yet through the sequencing, and our clinics are full of them. In fact, of course, I'll be retired in however years, it'll be my successors will be picking up all of these hopefully well-managed pieces to actually put onto their next very long remissions. I don't know philosophically whether you feel the same, Nick.
Yeah, it is like that. I mean, I think we should take these results as a proof of principle. I think that the venetoclax can be effective following venetoclax itself. But yeah, it is quite right that these are very, very difficult to treat patients, and we probably would expect better going forward. And this is just answering to our own eagerness and impatience to really unveil this data. And we need to find out if venetoclax can be used again, not us clinicians, but also obviously pharmaceutical companies are very keen to have their drug reused again, obviously, so they're keen to get this evidence out to demonstrate the principle of it. But obviously the bulk of the patients have still not received venetoclax again because they haven't needed it, and that's the bottom line. And it's the same case for the venetoclax at first line. So I was offered a study to retreat patients with venetoclax after they've received venetoclax obinutuzumab in the first line setting following the CLL14, and I actually had to turn down the study because I have not seen any relapse patients after, so I couldn't recruit to that study because the patients are still very well. So
yeah, well, that's a good news story as well. I'm going to finish. I've got one question which I'm going to put to both Nick and Renata. Sorry, it's a technical one about venetoclax continuous against venetoclax rituximab, because this is another thing that I debate with colleagues in Cambridge, that if you're enriched for the molecular profile that tells us you simply need ongoing therapy, you know, these unmutated or TP53 type of patient that comes off the back of Murano, we've got all the data that tells us these are the ones that enrich for early relapse. If we're going to reuse venetoclax, shouldn't we just put them on continuous therapy and just accept the fact that, you know what, they need to be on drug? Do you have that debate, or do you just go straight for Venar whenever you have the option?
I personally, so my own personal argument, and I have no evidence to back this up, unfortunately, is that you know, in my personal practice, the relapses I've seen after continuous venetoclax therapy have been very difficult to treat. And my personal view is that BCL2 is and the apoptotic mechanism is such is such a crucial pathway for CLL cells that once they manage to escape inhibition, it means that the cells are really aberrant and very aggressive, and therefore I think there's still a merit to avoid that, and the Murano has demonstrated that if you limit the duration of venetoclax, then you limit the emergence of these sort of perhaps very aggressive clones. And that's my personal take on that.
I mean, obviously, we don't have data to to go either way. I think you're right. If I've got a patient who I know has got really good bad prognostic features, those sort of suggestions we've seen it over the years, that sort of continuing treatment is probably beneficial for those patients. So rarely, and obviously I do go, ultimately I go what patients want to do. So I've got a couple of patients who are on venetoclax maintenance for that very reason, because you know, as you both say, you know, with those with really bad genetics, they tend to do badly. But whether, you know, what would be the difference with them who, if you would giving them fixed duration venetoclax rituximab, we don't really know that.
Yeah. Yeah, I just a cautious story. We had a patient in our region, not our hospital, who was put on venetoclax rituximab, but put on the continuous form on Bluetech. They had a short block of treatment, stopped, and then a few years later wanted to restart venetoclax, and they could not get it. Their pharmacist wouldn't allow it because they had apparently been treated on the continuous therapy Bluetech, which doesn't allow you to return to venetoclax. So they eventually got there, but it was quite a few weeks and appeals and a lot of writing. So you've got to choose your Bluetech form carefully, not in a rush in clinic. So I am going to hand over to Renata, who is chairing the second session with John, and I'll come back to join the panel discussion. And thank you, Nick, again. Amazing talk. Thank you very much.